So it's my pleasure to introduce our speaker today. It's Dr. Olivia Lee, who is an associate professor of ophthalmology here at UCI. Dr. Lee started at the Baylor College of Medicine in Houston, and then went to the New York Ear and Eye Infirmary Center, and then out to UCLA here on the West Coast at the Stein Center, I believe, and now is here at UCLA. Or a UCI. So Dr. Lee works in the anterior segment of the eye and has been applying confocal microscopy to look at different conditions. And so we're excited to hear about Dr. Lee's research.
Okay, thank you so much for coming. Thank you, Dr. Milner, for inviting me, actually. It's really a pleasure to be here. And thank you for those of you joining us on Zoom. May I ask everyone in the audience, other than you two, you're not in ophthalmology, correct? Or
I work, I'm not in ophthalmology.
Okay. I just want to know how much background information I should give about some of the diseases that I mentioned. Maybe I just give it a little bit.
Yeah, no, go ahead.
Yeah.
I think there'll probably be something.
Okay, great. Okay, so I wanted to, in this talk, give you an overview of my work on using confocal microscopy specifically for ocular surface diseases. In ophthalmology, we know very well that confocal microscopy is typically described as used for the diagnosis of a parasitic corneal infection called acanthamoeba keratitis, which is relatively rare. And so not a lot of places have a confocal microscope, and those that do tend to use it for that purpose. And I want to tell you about this clinical and research use of this device that I have had experience with for about 10 years. So here are my disclosures, although none are relevant to today's talk. Ocular surface diseases are, in general, fall within the larger umbrella of dry eye diseases. But what is really a dry eye condition? A group of experts came together and came up with this definition, which I just want to highlight as a set of multifactorial diseases that are characterized by the loss of homeostasis of the tear film. And the patients have symptoms, but also the tear film displays instability. And all of this ends up causing ocular surface inflammation and damage. So we're going to today focus on this ocular surface inflammation and damage. But in general, dry eye symptoms range from itching, burning, light sensitivity, hard to keep your eyes open, feeling like your eyes are very tired. And it's very, very common. I mean, I'm probably sure everyone in this room, if you sit at front of the computer long enough, or if you have the air conditioning blowing at your eyes, you've felt some of these symptoms at least at some point in your life. So to narrow in on the part of the eye we're talking about, if you're not familiar with eye anatomy, we're going to be talking about the front of the eye. The cornea is the clear covering in front of the eye. If you wear contact lenses, you're putting your contact lens on the cornea, but in front of the cornea is the tear film. And the tear film is not just water, and it's not just serving as lubrication for the ocular surface alone. It also is the initial refractive surface of the eye. It provides oxygenation to the cornea, which does not have any vascularity to itself. The tear film, again, it's not just water. It has three components. The mucin layer, which is the closest to the corneal epithelium, helps the tear film stick to the eye. Then the aqueous layer is the water layer, or the largest volume. And then the lipid layer is the most anterior layer. It prevents evaporation of the aqueous layer. And we also have biological functions to the tears, which provide an antimicrobial, anti-inflammatory environment for the eye. So if you have this loss of homeostasis of the tear film, you see you can get these areas where there's missing tears, and then the epithelium of the cornea is exposed directly to the air, which it's not supposed to be. And that will ultimately lead to some kind of damage to the surface of the eye. So here on the right, you see a cartoon of the normal surface of the eye. And you can imagine if it's as dry as this cartoon on the left side, that you're going to have visual disturbance from that, but also each of those little crevices where the tear isn't filling in, you may have damage to the underlying epithelium of the cornea. So how do we evaluate dry eye disease in the clinic? Well, this is our workhorse, the slit lamp. And if you've ever been to an eye clinic, everybody uses this. So we talk to the patient about their symptoms. We examine the tear film itself, and we look for any damage that has already occurred due to dry eye. So there are many ways to record the patient's symptoms, but we like to use this validated questionnaire. It just takes a few minutes for the patient to answer what kind of symptoms they've had over the last week. And they can do this themselves, and we calculate a score, and the higher the score, the more symptomatic, and that correlates with higher severity of dry eye disease. The corollary to that is the less symptoms you have, the lower score you have, the less likely you have dry eye. And this is just a video to show you just generally what it looks like when we examine, is that going to play? There. What it looks like to us when we look at the tear film. So we apply a fluorescein sodium dye to the tear film. And when we turn on the cobalt blue light, we can see that as lights up green. So you can see the tear film. Let me put on the laser pointer. You can see that highlights the tear lake that sits on the lid margin. And when we ask the patient to blink, and we can see that tear film move across the surface of the eye. And this is a normal exam. So what we're looking at here is the height of the tear meniscus as it sits on the tear. The tears sit on the lid margin, and we watch the surface of the eye and watch as the patient blinks, when do the tears first break up? That tells us how fast the tears are evaporating off the surface of the eye. So a normal tear breakup time is 10 seconds or greater, because on average, a normal person should be blinking every 10 seconds. But during the pandemic, a lot of people have been sitting in front of Zoom all day, sitting in front of their computer, right? And you're staring, and you're blinking less than 10, you're blinking like 15, 20 seconds. And so if your tears evaporate before the next blink, then there's going to be some period of time where there are these dry spots on the cornea. If this is severe enough, goes on long enough, you will have these areas of staining. We call this fluorescein staining on the cornea. These little green dots are highlighting areas where the corneal epithelium is damaged and or missing. So all of these little green dots, we tell the patient these are little micro scratches that have occurred, not because you scratch yourself, but just because the air is passing by your cornea and you don't have adequate tears to protect your eye from that damage. We have other dyes that we use as well, rose bengal, glycine green, but you'll see many of my slides have these kind of blue pictures, and we're looking at these green spots on the cornea. In extreme cases, in severe ocular surface disease, the end product of all of this going on chronically for a long time is you're going to get corneal and or conjunctival scarring. And these are two more extreme examples. We can also measure how much tear the patient produces. So we put these Schirmer strips, they're little strips of filter paper, and we put them at the corner of the patient's eye, have the patient close their eyes for about 5 minutes, and then we take them out and we can look at how wet these little strips are. And you measure that in millimeters, and a normal person should be making 10 millimeters or more of wetness on the strip. And so if you make only 2 or 3, that tells us you're not producing enough tears. We also always look at the eyelashes and the eyelid. So for example, here you can see these are the opening of the meibomian glands. The meibomian glands produce the lipid layer of the tears. In this particular case, you can also see they're very pouting. You can kind of tell that the oil in there is very thick, and it's not coming out like a thin, liquidy, clear layer. You can also see this person has an inflamed lid margin because they have these telangiectatic blood vessels on the lid margin, which should not be there. How about this person? Something is wrong with this person's eyelid, that they try to close the eye and they cannot close the eye. So what happens there is, even if this person is producing normal volume and quality of tears, their eyelid, which think of the eyelid like a paintbrush that paints tears across the eye and gives you a fresh layer every 10 seconds. If this person cannot close their eye, then this area right here will become desiccated, even if the patient is producing normal tears. So what I've shown you so far is what any normal ophthalmologist, optometrist has the ability to do these examinations for dry eye. And we routinely do them almost on every single patient. What I'm about to show you next are things that maybe a dry eye specialist would like to see this extra information about patients with ocular surface disease. So we have this mybography device in our clinic. It uses infrared light to be able to visualize the structure of the meibomian glands looking through the conjunctival surface. So this is a normal one. You can see these linear structures are the meibomian glands. They produce the lipid component of the tears that comes out from those orifices that I showed you earlier. Whereas this is a patient with atrophy of those glands. What else do we do in our clinic? So this is a point of service test where we take a small sample of the patient's tears just by touching the lower eyelid. We collect the tears at the end of the device. And I tell patients this is like a pregnancy test or a COVID test, and you read it very similar to that. So the blue line is the positive control, and the red line indicates the presence of an inflammatory molecule, metalloproteinase 9, in the tears. So a normal person should not have this red line, and the presence of the line indicates to us that there is inflammation present in this patient's tears. So I will come back to this at the end of the talk. And then this is what today's talk is about. In vivo confocal microscopy, again, I mentioned this is typically done for another purpose, diagnosing infectious keratitis. Is it going to play the video? Let me see. I think I need to take the laser off in order to play the video. That's too bad. I can't figure it out. Okay, so this movie is showing you what we actually see when we image the patient. In real time, we will see all of these images. So it is creating this movie where every 2 microns, it is taking an image of the eye going anterior to posterior in the eye. And I'll show you a breakdown of that later. But suffice to say, we're starting at the epithelium and going all the way into the stroma, and it's going very quickly. But we can actually freeze frame it at any point if we want to focus on any anatomic layer in particular. I added this slide in case any of you were going to ask me how confocal microscopy works, which is really not my focus here. But if you think about any kind of microscope that looks into a plane of dissection of a certain tissue, it's going to see what's on the surface, but it's not going to see what's behind that. But this device can look past with a single beam of laser deeper into the tissue. And that's why we can get so many beautiful pictures of the different layers of the cornea. And so this specific device is the one we have in our clinic, and it allows us to image the eye and get these beautiful in vivo histology photographs in a non-invasive, rapid manner. And by itself, it will move layer by layer through the cornea, and it gives us these beautiful high-resolution images, 400 by 400 microns. So we are seeing much more than what we're seeing at the slit lamp. So this is our research fellow here, Dr. Cynthia Kim, doing the confocal on a patient. Is it playing? No? There. So you can see that the patient has to sit very still with the head in the chin rest and the forehead there, and the device actually does touch the patient. However, the patient has topical anesthesia on the eye and a coupling agent, a gel, between the patient and the device itself, which has a disposable sterile cap to produce the area that touches the patient's eye, and we use a new one for each eye. And you can see behind her right hand what we're seeing on the screen during the exam. Is it playing? No. So you can see right behind her gloved hand that in real time, you are seeing all those layers passing through, okay? And then on the right of her gloved hand, you can see there's also a small camera that shows you where the device is touching the patient's eye. So this patient is looking straight ahead. We're capturing a central corneal image, and that's generally most often what we are doing. But if you have a specific lesion somewhere else on the periphery of the cornea, or you want to look at the limbus, you can ask the patient to look left, right, up, or down, and they have to maintain that focus while we image the patient. So it's really nice. We can see these beautiful high resolution images. So for example, here you see a blood vessel. You can actually see the erythrocytes moving in the blood vessel. We are here, we're going to talk a lot today about corneal nerves, and it's not, sorry, I'm having so much trouble. There. So these linear white structures are the corneal nerves, and the example I'm showing here is a very normal cornea with a lot of nerves and the normal branching structures that we would see. But you can start at the epithelium. These are epithelial cells, and it will go layer by layer deep into the cornea. So here's an example of each layer of the cornea that we can see. Going from anterior, you see the epithelial cells. There's 3 layers of the epithelial cells, the superficial, wing, and basal cells. Then we see this beautiful subbasal nerve plexus where you see the corneal nerves. And this is, again, a normal image. And we see the corneal stroma with its tadpole-shaped keratocyte nuclei. And then you can go all the way down to the endothelium. But for the purpose of today's talk, because we're talking about the ocular surface, we're going to focus on the top row right here. And so these are normal images, but in abnormal eyes, we can actually, of my interest, we can visualize the inflammatory cells in the cornea. And this is not something we can do clinically at the slit lamp. So on the left, this is an example of leukocytes that we see infiltrating the cornea in a case of bacterial keratitis. In the center, we see these spiculated corpuscular structures. We think that these are antigen-presenting cells of the cornea called dendritic cells, and this is an example of ocular graft versus host disease, which we'll talk about more. And on the right, this is an example of mature dendritic cells at a very, very high density in a patient with Stevens-Johnson syndrome, which is an acute, very, very severe allergic inflammatory reaction, usually to a drug, and it causes sloughing of the skin of the entire body and sloughing of the epithelium on the eye. So these are an example of things that we can see that doesn't have anything to do with looking for parasites. That is typically what this device is used for. In end-stage ocular surface disease, we just see scarring. We don't even see the structures, the cellular structures anymore. It's just overtaken by this kind of fibrosis and a little patch of some cells, but they're not normal looking cells anymore, and neovascularization. And again, there should be no neovascularization in the cornea, which is an avascular structure. So my introduction to confocal microscopy began when I was a fellow at UCLA. I was working with Sophie Dang, who is a pioneer in limbal stem cell deficiency. So we collected images using confocal microscopy of patients, all kinds of patients with different types of diseases that ended up causing limbal stem cell deficiency. And we categorized them by disease severity. And my job at the time, I was a fellow, I just sat there for hours and hours and hours and counted these cells, counted the nerves, counted the branching of the nerves. It was very tedious work. And but why this is important is because before this, the diagnosis of limbal stem cell deficiency required impression cytology, which was uncomfortable for the patient. We were ripping off epithelial cells from a patient who has a hard time regenerating their epithelial cells. It was painful, and we would send that to the pathologist to make the diagnosis. But instead, we could use this in vivo histology to make the diagnosis in a non-invasive manner. And you can get the answer immediately. You don't have to send it to the pathologist and wait a couple of weeks for the results. And so what we see here is that the normal morphology of the epithelium just changes over time. And in the severe stages, it's just fibrosis. You cannot even recognize the architecture. And you can see on the top right that the nerves that you see here are less than the normal nerves that I showed earlier. But as you go to the further stages, you're not even sure if you see any nerves here at all. So with that experience, I started thinking, well, what else could this be used for? I now started to think these superficial epithelial cells, the basal cells and the wing cells, these are the epithelial cells that are exposed to air when there's not enough tears. And then there seemed to be some change in the nerves in all these patients. So could this be applied to other types of diseases that we know cause inflammation in the ocular surface? So I picked these 3 conditions to study using the confocal microscope. And I think I obtained my first, I think I got the confocal microscope back in 2012 or 2013. And these were the patients that I just wanted to know, what could we see in these patients? So ocular graft versus host on the left, this is a condition that only occurs in patients having had received allogeneic bone marrow or stem cell transplant from another person. Usually that's done for some kind of blood cancer, leukemia or lymphoma or myelodysplasia. And the donor, or the bone marrow from the donor, is attacking the patient's tissues, and the eye, or specifically the ocular surface tissues, are often a target of that autoimmune mediated inflammation. In the center, we have mucous membrane pemphigoid. We used to call this ocular cicatricial pemphigoid, but pemphigoid is a systemic autoimmune condition that targets skin and mucous membranes. So you could get scarring and fibrosis, cicatricial changes on the surface of the eye, but it can also affect the inside of the mouth and the skin. This condition is typically treated with systemic immune suppression. And then on the right, we have Sjogren's syndrome, which is a systemic autoimmune condition that causes dry eye, dry mouth, often associated with other rheumatologic diseases like rheumatoid arthritis or lupus. So these are conditions that are known to be associated with inflammation. So I decided to look at these couple of diseases using the confocal microscope. So let's start with pemphigoid. So this is a condition that causes this very severe scarring that at first starts with scarring of the conjunctiva. So this is some symblepharon attaching the globe to the lower lid. But in very extreme cases, this is a terrible case of this lower right picture, the entire ocular surface is severely damaged. It cannot produce any more tears, and there's such severe scarring, the patient cannot look up, right, left, or down, cannot open or close the eyes. The lids are fused to the surface of the eye, and this person is, of course, blind. The staging of the disease is according to how much scarring there is. And in the bottom right, you see the most end stage, like the one I showed you earlier. So I took this is, by the way, a relatively rare condition, but it was one that interested me. So I was trying to ask people to send these patients to me. And so here's an example of a patient that's pretty far gone. She has a lot of scarring you can see on both eyes. And really the structures that's seen on confocal microscopy, you're just not resembling normal epithelial cells on the eye. There's a lot of fibrosis here, and there's blood vessels that you can see that, again, are not supposed to be in the cornea, but you can also see them clinically here. So I took in many of my slides, I'm going to show you just for your reference. On the left-hand side will be representative images from totally normal people. And, we have age match controls that we get. And interestingly, we try to get these age match controls from our clinic, from each other. And we noticed while we were doing this, that we would just ask each other, oh, you don't have dry eye, right? You don't have any eye disease, right? Okay, we'll just image you. And we found that even within our own colleagues, we couldn't even use people who have contact lens wear, because those were not normal either. So just to give you an example of like a totally normal person on the left, compared to the mucous membrane pemphigoid affected eyes. We had 14 eyes in the non-end stage group, so stages 1, 2, and 3. And then we had 16 eyes in the end stage group. And the end stage group, you really just lost architecture of any normal structures. You just see fibrosis, neovascularization, and you just really can't see much of anything. So we really couldn't even do any kind of analysis on these eyes. So most of it is on these 14 eyes in the non-end stage group. And just visually comparing the left to the right, you can also already see that the epithelial cells, the morphology of them has changed. We call this metaplasia, because there's the hyperreflectivity and enlargement of the cells means that they're desquamating at a faster rate than the normal ones. And we also see that there's loss or decreased density of the corneal nerves. So I'm going to show you that we looked very closely at the corneal nerves, and we looked at the nerve density, which was lower in the diseased group, the nerve tortuosity, which was increased, the nerve reflectivity, or how bright these linear structures look on confocal, was decreased. And the normal eye has a few dendritic cells or antigen-presenting cells of the cornea, but you can see a lot of them in the pemphigoid patients. So let's quantify this data. So the density of nerves was lower, and this was statistically significant in the mucous membrane pemphigoid group, even though our N is quite small. The tortuosity of the nerves was increased, but that's not statistically significant. The reflectivity of the nerves was decreased, and that was statistically significant. But most importantly, the dendritic cell density in these eyes was higher than normal controls. Even though I will say I did not control for if these patients were treated or untreated. But in general, if this patient is in my clinic, they're not going to be untreated. So I didn't even take into account the stratification of the disease of whether they were treated, what they were treated with. So I think probably this means in a completely untreated patient that this is actually even higher than what I'm showing here. So then we're looking at ocular graft versus host disease. So again, this is the condition that only happens in patients who have had a bone marrow transplant and the donor's immune cells are attacking the patient's eye. So similarly, we look at the control on the left compared to the affected eyes with clinically diagnosed ocular graft versus host on the right. And so again, you see the epithelial cells are enlarged, hyperreflective. You see this metaplasia. You see that there are hyperreflective nuclei visible in these cells that aren't present here. And just in general, the cells are larger, meaning that we think that there are more cells present in the normal eye and then in the diseased eye. How about the nerves? Very similar: decreased density, increased tortuosity, decreased reflectivity, and again, presence of dendritic cells at a much higher density than compared to normals. So same data, the nerve density quantitatively was lower in the graft versus host patients. The nerve tortuosity was lower, the nerve reflectivity was lower, and there were more dendritic cells in the graft versus host eyes compared to normals. In this group, I then took the graft versus host eyes and divided them into my clinical diagnosis of whether I felt that this patient had active disease or inactive disease. And the person who is doing the analysis, the research fellows, are blinded to my clinical diagnosis. So even then we divided that group, and you could see that the active patients had higher dendritic cell density than both the inactive and control, although this wasn't really statistically significant, we think because the N at that time was too low. I think I published this in 2017. I haven't updated the data. I should, because we have a lot more patients now. And so I think that this would be statistically significant. But also I have to say, back then I was kind of naive. I thought that the disease was like a light switch that you turn on or you turn off. It's black, it's white, it's either active or inactive. But I think it's much more nuanced than that. I think that my diagnosis of whether it was clinically active or inactive was based on the patient's symptoms, the exam. But as I showed you previously, the exam we do with the slit lamp is very big picture. You know, I'm looking at, is the eye red? Are there fluorescein staining on the cornea? But I can't see what the confocal can see. I cannot see individual inflammatory cells, much less can I quantitate them at the slit lamp. So I will come back to that concept later. But I also realized I did a lot of this work in these kind of rare, very severe ocular surface diseases, and I was seeing a lot of those at the end stages. Maybe I should be looking at the more common dry eye conditions. So we looked at Sjogren's versus non-Sjogren's dry eye. And non-Sjogren's dry eye, what I mean by that is a not necessarily systemic immune modulated, like, you know, any very common, like any one of us could have this kind of dry eye, not associated with a systemic autoimmune condition. And even those patients had changes in their nerves and increased density of dendritic cells. But could I use this device to differentiate between the non-Sjogren's and Sjogren's eyes? So we looked at the Sjogren's eyes too, and they indeed were more severely affected by confocal. We could see less dendritic, more dendritic cells and less nerves. So we also realized we could use the device to quantify the number of epithelial cells. So we did that for the Sjogren's patients, and you can see that indeed the epithelial cells are of lower density in the Sjogren's syndrome patients compared to normal controls. We also wanted to know, are these things that I'm seeing, are these just some esoteric finding? Am I getting lost? I'm losing the forest for the leaves on the tree. Is this actually correlating with what the patient feels or with disease severity? So then we started correlating this with patient symptoms. So the patient would fill out a survey, the Ocular Surface Disease Index survey that I showed you at the beginning. They would just answer a couple of questions and we would get a score. So for your reference, the lower the score, the less symptoms. The very high scores are associated with more severe dry eye symptoms. And so you can see, as you would expect, the Sjogren's syndrome dry eye patients have more severe disease, they have more symptoms, and that's statistically different than the controls. So that makes sense. But then we looked at the nerve density, and like you would expect, based on what I showed you earlier, the nerve density is decreased in both groups compared to control, but especially the more severely affected dry eye patients had less nerves. How about the nerve tortuosity? Similar. And how about the nerve reflectivity? Similar, maybe not statistically significant between the two groups. But the dendritic cell density, so how many inflammatory cells are present in the Sjogren's syndrome patients, who we know is an autoimmune mediated inflammatory disease, was higher than the patients without Sjogren's syndrome and with the patients with no dry eye. But even the patients without inflammatory mediated dry eye had higher dendritic cell density than control, but it wasn't statistically significant. Okay, but do any of these things correlate with each other? So yes, the nerve density and dendritic cell density did correlate. In other words, the patients with the worst nerve density, lowest nerve density, had the highest dendritic cell density. So the more inflammation you have, the less nerves you have. How about symptoms? It did correlate. So the patients who have the most symptoms, the highest OSDI survey scores, had the most symptoms, had the highest had the lowest nerve density, and these blue dots over here are the normals. So they have normal nerve density and no symptoms. So this was statistically significant as well. And then we correlated the patient's symptoms with all of these other findings that we've been looking at on confocal. And indeed, they all correlated. So the more symptomatic the patients were, the worse the nerve reflectivity was, and the higher the dendritic cell density, the worse the patient felt. In other words, the higher the OSDI score, the higher the dendritic cell density. And again, that was statistically significant. So that tells me that what I'm looking at is not just me by myself looking at a screen, but that it does correlate with patient symptoms and maybe disease severity. So does that mean that if I use my confocal findings as clinical endpoints, try to improve those confocal findings, that will the patient feel better? Will the patient get better? That is a question I'm going to come back to a little bit later. So the next thing I did is, well, what if I just pick a disease that's not even that's like, I picked this drug toxicity condition because I wanted to take something that wasn't inflammation from a systemic condition or a local condition, but an iatrogenic one. So we looked at patients with glaucoma, which is a whole different condition by itself. Generally speaking, that causes high pressure in the eye, which then affects the optic nerve and the patient loses peripheral vision. But the treatment for that condition focuses on decreasing the eye pressure. And most patients use eye drops for that purpose. So there are many eye drops on the market, and the patients using these eye drops tend to be using them for years and years, if not decades. And the patients with more severe glaucoma need to use multiple drops. And these patients all get dry eye. Is that from the preservative in the drops, or is it from the toxicity of the drops themselves? That's debatable. But anyway, we looked at those patients compared to controls and very similar findings. So not to bore you, because it's all the same, really, that the higher the symptoms were correlated with the patients who were on glaucoma drops. And the patients on glaucoma drops had lower epithelial cell density in both the wing layer and the basal layer. They had decreased nerves, they had increased tortuosity, decreased nerve tortuosity, and more dendritic cells. So they had inflammation in their corneas, even though this was a drug, assumed to be a drug effect. So it seemed like all of these conditions affecting the ocular surface had these things in common: decreased epithelial cell density, decreased or presence of dendritic cells at a higher density than controls. And it seemed that the more active the disease or the more severe the disease, the higher the dendritic cell density was. And that we saw multiple changes in the nerves, not just decreased nerve density, but the nerve tortuosity was increased and the nerve reflectivity was decreased. And this seemed to be universal to all these ocular surface diseases that I looked at, whether they were traditionally thought of as associated with inflammation or not. And in the advanced stages of all these diseases, then you just stopped being able to recognize the normal architecture. So I started thinking, let's not even worry about the advanced diseases. Let's worry about how we prevent the patient from getting to that advanced stage. So I want to now tell you where we're going now with this information. Where do we go forward from that? So I started to ask myself these questions. Can confocal microscopy be used clinically to diagnose and treat the patient? So could we use our confocal microscope to give us some information that would tell us prognostication? In other words, which patients are going to progress, which patients are going in that bad direction and we need to stop them, which ones are going to develop the severe disease. Could we stage diseases like we staged limbal stem cell deficiency using confocal findings alone? And this one, monitoring and guiding treatment. So I presented this data at several meetings. Each paper was published individually, and I always got the same questions from the audience. It was always from the clinicians in the audience asked me, okay, so you see these dendritic cells and you see this nerve decrease in these eyes. Do you use that information to help guide your treatment? And in the early years, I always said no. I just wanted to know what's going on. I just wanted to observe what was happening. But after I compiled all of this, it was undeniable that this was a commonality in all these diseases. So without meaning to, I started adding that information into as a puzzle piece in the big picture. I would look at the patient, ask the patient questions, look at the exam, but I would also walk over and look at the confocal. And so without realizing, I was incorporating that into my treatment strategy. So to that end, can response to therapy be assessed using confocal corneal findings? So I'll give you two examples here. Neurotrophic keratitis. We talked about loss of nerves as a result of chronic inflammation from a variety of diseases. So here is a disease that's caused primarily because of a damage to the nerve from a known cause, whether that is the patient had a stroke, the patient had a brain tumor that was excised and then the nerve was cut, or they had a viral infection that affected the nerves. But the end result of that is here's a normal eye on the left for your comparison, and this is the patient's affected eye. This particular patient had a brain tumor. And so you see that there's this epithelial defect. A lot of patients misunderstand. They think we tell them that they got a corneal abrasion or a scratch on the eye, but this is like the patient got physically scratched with an loss of epithelium, but they never had any trauma to begin with. It is simply a result of loss of innervation to the eye. And any person who's had a corneal abrasion will tell you it's extremely painful. It's so painful that people go to the emergency room all the time for corneal abrasions, but this patient doesn't have any pain. And this can happen for a variety of reasons. In that particular patient, it is because she had had a brain tumor. And so that was a known cause. Now there's a treatment for this condition. It is called Cenergermin, or Oxervate is the trade name, and it was FDA approved with orphan drug status a couple of years ago. It is a recombinant human nerve growth factor. So it's very unique in its ability to promote nerve regeneration, and it's just a topical eye drop. You give it every 2 hours for 8 weeks. And the clinical trial just looked at whether or not these epithelial defects in the cornea healed by the end of treatment, and that's how it got FDA approved. But they did not show that actually the nerves regrew. But that's what we're trying to do. So we use the confocal microscope to check if there are any nerves. So this patient didn't have any nerves. And just halfway through the treatment, 4 weeks, the whole treatment is 8 weeks, we already see some baby little nerves growing back. So this was a nice correlation with what the drug is supposed to do. And so we have been collecting these patients for maybe like about a year or so. And here are our first 5 patients. I think now we probably have some 20 patients. And the before and afters, you can see that there were epithelial defects or some kind of staining on fluorescein staining of these eyes. This is the one that I was showing you earlier. Number 4 patient is the one with that I showed you earlier with the epithelial defect from a brain tumor. And all you can see with the blue light, there's very little or no epithelial staining after treatment. But that's not new. That's what the FDA trial showed. How about the nerve regeneration? So patients 2, 3, and 4 showed some regrowth of nerves by the end of treatment. And when we quantified that, all of the patients before treatment had no nerves, 0. And the nerve density in those 3 patients, it quite varied, but between 1,600 to 3,000 nerves per millimeter squared. So that's definitely impressive. And we are going to continue following the patients for months after treatment to see if it continues to improve, which they say it should. So, but how about let's go back to the dendritic cell density in patients with various forms of dry eye. So again, I'll show you the control eyes on the left just to give you a point of reference. This is a patient with ocular graft versus host disease, again, a form of dry eye. And so we can see that in February of 2021 on presentation, there are essentially no nerves in the right eye or the left eye. And there's a lot of dendritic cells in the right eye, and there's some in the left eye. I think you can all see that. So we treated this patient with topical cyclosporin. So cyclosporin is an immunosuppressive drug that was originally used for autoimmune disease and kidney transplant patients. But in this scenario, it is made into a topical eye drop and used twice a day to suppress inflammation without steroid. And so you can see 3 months later, look at what happened to the dendritic cells. The dendritic cells almost all disappeared. and even some nerves started to grow back. So that's very nice for us to see. And I think that's why unconsciously, without collecting the data over the years, I had been seeing this improvement, and the patient was feeling better, and I just hadn't put it all together. So I had a medical student asked to come do research with me after I came to UC Irvine maybe a year ago. And so I gave her this project. I said, I've been doing this for years and just not collecting the data. Can you just collect the data for me? So prospectively now we are imaging the patients before we start cyclosporin and then giving them 3 months of treatment and having them come back. Now this is still in progress, so this is very preliminary results. We only have 20 eyes so far, and we use 2 different brands of cyclosporin depending on what is covered by the patient's insurance, but most of them will get the lower potency one prescribed first, more for insurance reasons than anything else. So you can see that the dendritic cell density went down after treatment, but more dramatically in the higher potency group. It's just not statistically significant in either group yet, but this is an ongoing study and I'm just showing you some preliminary data. But we're very encouraged by this because I already knew that this was happening. I just didn't have the data to show it. And so we're continuing this now, but I'm thinking already to the next step is, can response to therapy be titrated using our confocal microscope detection of dendritic cell density in the cornea? So we're thinking about starting a study, a clinical trial, where we start the patient who has dendritic cells in the cornea on the lower potency drug, give it a couple of months, see it decrease. Maybe it decreases by 60%, let's say, but not 100%. Then if we increase to the higher potency, will it then decrease even more? So we are in talks with our perhaps industry sponsor to work on this as a next step. But another question that came up is, can we predict or identify risk factors of disease progression using our confocal microscope? So to put this into context, I'd tell you a little story. So because of my interest in ocular graft versus host, I knew a lot of the hematologists in the area, and I would ask them to send me graft versus host patients. But inevitably, they always sent the really, really severe patients who had already been suffering for years. And whenever they first met me, they would say, where have you been for the last 5 years of my life? I can't even open my eyes every day. If I knew that this was going to happen from my bone marrow transplant, yeah, I know it saved my life, but I might have not done it. I mean, that's very, very sad. So I started saying, please send me the patients earlier. So back when I was at USC, they weren't doing a lot of bone marrow transplants, so they could send the patients to me early. And so I remember the very distinct one patient that was diagnosed with skin graft versus host. The patient didn't have any eye symptoms, and the oncologist asked me, oh, can you just take a look? Just make sure, right? So the patient comes, she has no symptoms. The ocular surface looks pristine. The eye exam looks totally normal. If I had not spoken to her, if I had not looked at the chart and I just looked at the eye, I would have thought it was a totally normal patient. But there were a few dendritic cells on the confocal. And then 3 months later, bam, she comes back with acute full-blown ocular graft versus host disease. So that put in my mind the idea for this. So now we are doing a collaboration with the UCI program about 2 years ago. So it's in its infancy. They are currently doing about 25 transplants per year. So that's a good number for us to be able to process. Before I worked with City of Hope, they were doing hundreds and they just could not send all the patients to me. That's why they sent them at the end stages. So now Cynthia and I are working on this natural history study. We have the patients come before their transplant because this is a unique disease in that we know time zero. We know before the transplant, it is impossible for the patient to have the disease. You can only get the disease if you have a transplant. And unlike some other diseases like a chemical injury or some natural occurring disease, you don't know when that's going to happen. But this, you know, because the patient has a date for when they're having their transplant. So we can see the patients before the transplant, and then we can see the patients after the transplant. And we don't know when or if they will develop graft versus host disease, but my idea is that maybe the confocal would give us a clue, like it did for that one patient. So this is something we started in February of 2020, and this is a maybe 2-month-old slide. So we have some more patients now, but we've screened what do you think, like 30 some patients, some 30 patients. And of those, we've had a couple come back now after months after the transplant. You know, some were waiting for the transplant. Not all of them make it. Some of them after the transplant, they're still very sick. They can't come back, but I just show you an anecdote. This is a patient who had a stem cell transplant for acute leukemia and was diagnosed with skin graft versus host disease, but the patient had no ocular signs, no ocular symptoms. And so you can see that before and the after are totally normal. There's no, green spots on the cornea, so there's no staining. The patient has no symptoms. But that MMP9 test that I showed you at the beginning, the point of service test where we take a little sample of the tear and it tells you, like a COVID test, whether or not you have metalloproteinase 9 in the tears, was very mild before and now is a dark red line afterwards. But more interestingly, look, this patient has some dendritic cells after transplant that weren't there before. So I said, we need to watch this patient carefully and see if this patient is going to get ocular graft versus host. So we just don't have enough patients to tell you the answer to this yet, but that is my hope, that we take these, I would call them subclinical findings that I wouldn't have known if I just looked at the patient, if I just talked to the patient, but things that I see only because I have a confocal microscope. Does that information translate to something I can do to diagnose the patient early, or treat the patient early, or better yet, treat them so they prevent developing the disease? That would be the ultimate goal here. So thank you for putting up with me. These are my take-home messages. So confocal microscopy is a non-invasive imaging modality that provides high-resolution images of the cornea at the cellular level with in vivo histology in a non-invasive manner. We can see microstructural, or let's say subclinical, changes to the corneal epithelium, corneal nerves, and these are consistent across a variety of ocular surface diseases that occur from different etiologies. And we can use confocal to detect and quantify the presence of dendritic cells in eyes affected by inflammatory ocular surface diseases. And that dendritic cell density improves with treatment. So maybe we can use these in the future clinically for early diagnosis, titrating therapy, and my hope is one day we can use it to prevent disease. So I would like to thank all the members of my research team, Dr. Cynthia Kim especially, I want to thank, because she came all the way from Brazil because of her interest in ocular graft versus host disease to work with me. And all of the recent data that I've showed, those are all her images. And Melissa just joined us from Turkey. And then there are several medical students who helped over the summer to obtain a lot of the data that I've showed. And then my colleagues in the cornea division also often refer us patients for our studies. But rarely do I get to thank my husband because he never gets to come to my talks and he doesn't know like what I'm doing every day, but he puts up with me. So I want to thank you for your support too, Elliot. So thank you very much. Any questions?
Thank you. That was great. Questions?
If the early detection of the dendritic cells gives you a heads up that ocular host versus graft disease is likely to manifest, are there existing treatments for ocular host versus graft that could be preventative measures, or is that to be developed?
I mean, I don't think anybody knows the true answer to this question. There are some groups that start the patient on topical cyclosporin before they have any signs, symptoms. They just start all the patients on topical cyclosporin when they get their transplant. But we don't have data to know, does that actually make a difference? Because no one is doing this kind of natural history study. So for me right now, because we're just doing an observational, non-interventional study, our decision is we're going to treat the patient we're not going to treat the confocal. We're only going to treat the patient who meets the diagnostic criteria, and we follow the guidelines of standard of care. That's our decision for the present moment. Of course, in the future, my goal is to answer that question.
Thank you. Other questions? I have a few questions. So
Oh, sure.
the field of view, you mentioned the field of view of the instrument you were using, I think was 400 microns.
Yes.
How much, I guess, many questions. So for your different applications, how many spots on the cornea do you normally collect data from? Do you see a lot of variation over different sites? And
Yeah. So for simplicity, we just try to always do central cornea. It's easier for the patient to maintain their gaze looking straight ahead. But because it's so highly magnified, it's true. We don't know if we're getting the exact same spot today as we do in 3 months. We don't have a good way to know that. There has been another group who's talked about doing an extensive mapping of the cornea to be able to put together, extensive view of the cornea and then know, well, this spot corresponds to this spot that before and after. I think while you could do that in theory, that means the patient's got to sit there for like hours, and it's hard for the patient to comply with that. So it's true, could be sampling error there. In general, we try to just take as many images as the patient can take, which is actually not that difficult because we're not taking individual images. We're taking movies, and naturally the patient will move like slightly. So some of the images are not good quality, and we are selecting the best quality images to examine. And when we do the data analysis, sometimes for the more severe patients that we really just couldn't even find good areas to examine, then maybe we just did the highest quality images. But for some of them, we would get 2 examiners. They're blinded to each other, so they don't talk to each other, and they examine the same 3 images. And then we want to make sure there's reproducibility between the 2 of them. And the examiner is always masked to the clinical scenario. So we try to do that. It's very difficult to know that we're getting the same spot again.
yeah, one of our faculty, Dr. Ballou, is doing in vivo confocal microscopy in the skin. And she has a little company and so forth, but her most recent microscope, I think, is like has a 1 centimeter by 1 centimeter field. So
that's big.
That's quite large.
Yeah, for us.
Confocal microscopy. Yeah.
Mhm.
So I guess my question was also just, do you expect that there might be not so much, air, but for different conditions, you would expect certain kinds of variation, and being able to look at a larger field may help you diagnose different conditions better? I mean, would you expect maybe to see certain parts of the cornea to look differently than, say, the central, and that might actually be a better, an alternative or another diagnostic for certain conditions?
Maybe. I could give the example of, we often do multiple spots for a different condition, infections, for example, because for an infection, we can clinically say, this is the area that's infected. And then we can say, let's image the infected area and then multiple spots around the infection. I think for this, the whole eye in general is being exposed to the same tear film, with some exceptions, right? Because if the patient has an eyelid closure issue, then there are some areas that aren't affected, some areas that are affected. So this is a good question. And I think we could do that. Again, it would take a lot of time for the patient and require a lot more cooperation from them. But yes, it is something that we could do. And if we thought that there were particular diseases that had localized pathology, yes, we probably should do that.
Other questions? I had another one.
Sure.
So it's fascinating. So I'm wondering, actually, you got to this range of questions at the end of your talk about diagnosing alternative conditions. So are there other like heart disease or other conditions that you might look at in the cornea
Sure,
to
we could
see
look
an
at
early,
really anything.
right?
Not a lot is being done. Like not a lot of people have this device, and the vast majority of the ones who have it use it specifically for infections. And but there are quite a number of us around that like this kind of topics, and so there are. I focused on the inflammatory ocular surface disease because that's my clinical interest. But sure, when it comes to, for example, the neurotrophic keratitis that I presented, we could examine a whole bunch of diabetics, and I'm sure we would find a lot that have decreased nerves because we know these diabetics get peripheral neuropathy. Same thing, they get neuropathy on the eye. So we could look at that too. And what was the other one? You said heart disease.
Heart disease, yeah.
I mean, I hadn't thought of those things, but yes, all these could be done. There's very little known about that.
Yeah, like even looking at patients on statins versus not, right? Because that affects lipid production. Might see a difference there. So any other questions? I have one more.
Sure.
Do you notice any difference between, say, the same patient beginning of the day, like morning versus end of the day? Is there a daily variation?
We have not looked at that.
Okay.
Yeah, we haven't looked at that, but we could. For example, we once did a little pilot study about tear osmolarity. So I didn't talk about that, but that is another dry eye test to look at the osmolarity of the tears, because the more concentrated the tears, generally that means you have more solute than liquid, right? So, we did this little study where we took this, like all of us volunteers, multiple times in the day. And, my conclusion was like, oh, this device doesn't work because there's just too much variability. It's like changing all the time. It's only the same person, same day. But you're right. It's probably because the longer you're awake, the longer your eyes are open, the end of the day, everybody's eyes feels more tired because you've been staring at the screen or your phone or whatnot, right? So yes, we could. I usually have been thinking, oh, some of these confocal changes probably takes months to change. So we've been doing them every 3 months, just with my assumption that it would take that long for the dendritic cells to go away, or it would take a very long time for the nerves to grow back. This was my assumption. I think I could very well be wrong, because we saw the nerves grow back in that oxyrvate patient 4 weeks later. Of course, that's with a recombinant nerve growth factor, but still, we have only been doing them every 3 months because of my assumption that it wouldn't change. But should we do it more often? Sure. But within the same day, that I don't know.
There was a study that just got published out of, I think, Western Australia. They were using OCT to look at the posterior segment, the retina, and look at all sorts of different things. But the purpose of the setting, send it to you, was the daily variation. And it was shocking to me how much variation there was just over one day. And I shared it with someone, and the response was, oh yeah, that's why when I wake up in the morning, I can't see very well, which was the power of the eye actually varies. So it was just okay. Well, if that's no questions, I want to thank you very much. That was an excellent presentation. Very interesting. Thank you.
Thank you.